Let's take a step back to 2009 at the beginning of this debate that gave us the Patient Protection and Affordable Care Act, otherwise known as Obamacare, in March of 2010. The promises were simple and they were compelling. They promised to lower the cost of health insurance, improve the quality of care, and make sure that everyone was insured. Unfortunately, though the goals were simple, the law that passed was not. The extraordinarily complex law remains unpopular 4 years later. According to the latest Rasmussen poll, 56% of voters view this health care law unfavorably, and 51% predict that the law will hurt, not help, the quality of care in America. And as we have all heard, the costs are generally going up and not down. Then there's the issue of the uninsured. Provisions to the guaranteed universal insurance coverage were an individual mandate and an employer mandate. But even under the best case scenario, which included Medicaid expansion, the number of uninsured was projected to still be about 27 million, down from 56 million. With the recent cancellation of policies, I've read estimates of that there will be as many as 50 million Americans without insurance. My point here is that the problems of dealing with the uninsured have definitely not gone away and are not likely to. And of course, we're well aware that the indigent and low income among the uninsured all too frequently utilize the emergency room when they need care. What recent studies have shown is that Medicaid patients, too, overuse the costly emergency room. In Texas, the burden of non-Medicaid indigent care falls to the counties. Only if a county spends more than 8% of their general tax revenue does the state kick in funding. But whether we're talking about indigent care or Medicaid, the population that we're talking about is generally the same. Our panel today will talk about two innovative programs that counties have developed to deal with indigent care, and we'll also discuss Medicaid, a broken program that has long been in need of fundamental reform, not expansion. So our panel today there's one change from the program that you were given. Art Hour, who is going to be talking with us from Collin County, is not well. His doctor said he could not travel. And so thank you, Terry Esposito, for filling in for Art Hour. Terry is the Executive Director of Project Access Collin County, a program that takes care of indigent patients in Collin County, which is adjacent to Dallas County on the north, and includes Plano, Allen, McKinney, and Frisco. The program is fully funded by a combination of grants from the Collin County Commissioners Court and all 10 hospitals in Collin County. Terry started with Project Access 2 years ago as the Assistant Executive Director. She was then promoted to the Executive Director position after a year and remains in charge of the program. Project Access enlists primary care physicians to volunteer to care for indigent patients. Also cared for are the qualifying patients referred from the participating hospitals and the specialty physicians who volunteer in the program to care for patients. Pharmaceuticals, imaging, lab support, and hospital care are also provided. And she's here today, as I said, to take the place of Art Hour, who is the Executive Vice President of this initiative and also the Executive Director of the Collin-Fannin County Medical Society, which is the organization that created this Project Access. I'll go ahead and introduce all three panelists and let them come up one at a time, and then we will have questions and answers. Or you will have questions, and I hope that we have answers. George Hernandez is President and CEO of the University Health System. The University Health System is an academic medical center and county-wide hospital district located in Bexar County, Texas. The health system serves as the principal partner of the University of Texas Health Science Center in San Antonio and helps train over 2,500 healthcare professionals annually. The hospital system also owns and operates 19 primary, specialty, and preventative care centers throughout Bexar County. They own a nonprofit HMO called Community First Health Plans. They own a nonprofit multi-specialty physician practice, Community Medicine Associates, and it's a 50% owner of San Antonio Air Life, an air ambulance program providing emergency transportation service to Bexar County and South Texas. George Hernandez has served as the 2013 chairman of the Texas Hospital Association, just retired off of that, and he says back to his normal life. He served as a member of Code Red Task Force on Access to Healthcare in Texas, the Texas Health and Human Services Commission's Medical Care Advisory Committee, the Board of America's Essential Hospitals, and is past chair of the Teaching Hospitals of Texas. And then we have Senator Charles Swertner. Senator Swertner is a former state representative and practicing orthopedic surgeon in Williamson County and in Milam counties. In 2010, Senator Swertner was first elected to serve the people of House District 20 in the Texas House of Representatives, where he was a member of the House Committee on Appropriations as well as the House Committee on Public Health. In 2012, Senator Swertner won the Republican primary for Texas Senate District 5, a 10-county region of Central and East Texas. He serves as a member of the Senate Committees on Health and Human Services, Government Organization, Criminal Justice, Agriculture, Rural Affairs, and Homeland Security. Last September, he was also named to the Sunset Advisory Commission, a 12-member legislative body charged with providing a comprehensive periodic review of the operation of more than 150 state agencies. He's received numerous honors, but his most important honor is that he is the father of 3 sons with his wife, Belinda, who is an obstetrician and gynecologist. So help me welcome all 3 of our panelists, and Terry, would you please come forward?
Well, thank you very much for having me here.
Thank you for filling in.
I am happy, nervous, happy to be here. So I really do appreciate it. I am the executive director for Project Access Collin County, which I'm very proud of this nonprofit organization. Helped get it started back in 2011, and June 1st we opened up our doors in a space rented or donated from our county. And you'll see through some of the things I'm going to talk about our program. I already mentioned the county once, and that's going to be a key as far as what our program is and the success of it. So like I said, we began a program June 1st, 2011. We had a group of 18 patients and maybe about 10, 15 physicians, and already a waiting list for specialty care. So we had a lot of work to get started with that. Since then, we have grown to have served over 400 patients at the end of this year. Served our physicians, have donated with 70% reporting. We're projecting over $1 million in medical care. So what are we and what do we do? We are a nonprofit organization that delivers health care to the uninsured and indigent in our county. How do we do it? Well, first you have to have funding. Then you have to get somebody to provide the care. So that's a challenge. The other thing you have to do is hope that if you have to care for a patient and they get sick and do need to go to the hospital, you need hospital care. So this organization started by Art Hour in collaboration with many different organizations, and especially our county commissioners decided, yes, we'll go ahead and fund it. Why? Why would you fund this type of an organization? Because we can save the county money. Really? I like the sound of that. Let's save the county money. How are we going to save the county money? Well, as the executive director of the Collin Fannin County Medical Society, I bet my physicians would volunteer to see the indigent patients under charity care. For free? Well, we sure would save money, right? Why would a physician volunteer to see a patient for free? Well, we're very fortunate in our county. We're a wealthy county. The other thing is, if I can promise you as a physician that I'm going to support you in that charity care. You can see Mrs. Smith, and if Mrs. Smith needs insulin, by golly, we're going to make sure Mrs. Smith gets her insulin. If Mrs. Smith needs a little bit of a diabetic education, all you have to do, doctor, is call us. Send us a form. We're going to make sure she gets what she needs. Okay, what does the physician get out of this besides charity, giving his charity care? Well, we are now a resource for our physician that if they've seen another patient for many years in their office, and you know, with the economy, we've had a lot of people unemployed. A physician may have been taking care of a patient for 10 years, and all of a sudden they lose income, no unemployment, no insurance. Now the physician has a resource to send the patient. He can continue to care for that patient, Mrs. Joan, and Project Access will step in and support him. We'll provide the medication, we'll provide the lab, and we'll even recruit his friends to provide the specialty care, whether it's gastroenterology, neurology, oncology, etc. So that gives you a little bit of how Project Access works. What are the other challenges? Well, we've got funding. There's probably, I would say, 50 Project Accesses across the country. Not all are as fortunate as we are. Their funding is your number one challenge. You have to develop budgets. You have to project how many patients you're going to have in your program. What is your cost to prescriptions? And what dollars can I spend to improve the efficiencies of my system? So you get funding, and especially consistent funding is going to be key to that. So we're very fortunate mentioning our county again. The other thing is the support of the medical society, because when I talk to physicians, the support of the medical society is who supports the physicians in the county. So that's a collaboration. And the other reason, or the third piece to that is to the hospitals. So we haven't talked about that yet. Why would a hospital donate free care to patients? So, well, if you're a hospital administrator and I am going to help patients, we are going to assign them to their own primary care physician. And that's a difference in Collin County. We don't send our patients to clinics. We send them to their own primary care physician. We support that primary care physician and send him anything he needs as far as specialty, ancillary, lab, etc. What is that going to do to your emergency department when somebody shows up with no insurance and they are at 200% or less of federal poverty level? Can they pay that emergency department bill? No. Are they using your emergency department for primary care? Yes. So that's what we do for the hospital. We have shown a marked reduction in the care needed for these patients to visit the emergency departments. What happens after Project Access? Our program is designed for 12 to 18 months. We have seen firsthand the care needed for patients or people who have gone without medical care. If I make $10 an hour and I have a choice between paying for my medication or insulin and feeding my 5-year-old child, I'm going to feed my child. So we've seen the outcomes of the care that's necessary for somebody who has not received care for many years. They require many primary care physician visits. They require, on average, three specialist visits. So we give them the attention they need. You also have a lot of health barriers for these patients that we work with. Not everybody has a good understanding of their own medical care or medical terminology or health care. Not everybody has food. So I can give you health care, but if you're not eating, we're going to have problems. I can give you health care, but if you have a mental illness, you're going to have a harder time getting better. So Project Access has a team in place where we do a lot of navigation. So it's the medical care that we're providing. We're going to support the primary care physician in everything he needs, but then we're also going to identify the barriers that the patients have as far as getting better. Is it transportation? Is it food? And we're going to develop care plans for these patients. That's something new that we started this year. Last year, 2012, I would say 30% of our patients who left our program were able to go back to work. We're able to get insurance. So that's good. Can you do better? Yes. All we have to do is research and look. How can we help the patients do even better? This year, because of our navigation, which is a key piece, 52% of our patients who have left our program have been able to go back to work. So we've raised that number. So it's about delivering care. It's about being efficient in that care. And it's about working with the patients and identifying what their barriers to keeping care or accessing care. So with that, thank you very much. And again, I appreciate being here.
Thank you. Thank you.
Great, thank you. My name is George Hernandez again. I'm the CEO, University Health System in San Antonio. I also have 3 kids, a little bit older. My oldest is a physician. He's an Air Force physician stationed in Hawaii. Real tough break and tough duty. And a son who is an engineer who works for Disney, also has tough duty. And then a daughter who's following more in her dad's footsteps, who's has a master's in public health and working for Parkland Health and Hospital System in Dallas. A little bit about the problem of the uninsured. I'm going to try to divide the presentation into 3 parts. The first part is really just to talk about the problem of the uninsured in Texas. And the second part is to deal with what we do in Bexar County to try to address the uninsured in Bexar County. And then the third part is to get into a little bit of the details of our CareLink program, which is the program that Arlene mentioned earlier, that we've been experimenting for about 17 years now. So when you look at Texas, Texas is an outlier. When you look at the percentage of uninsured in the country, and this particular chart comes from the Texas Comptroller's Office that was prepared back in 2005. Texas is 24% plus, and it's not Minnesota, it's not Vermont with small problems. It has a huge problem, and that problem is magnified because we're a big state, and it's magnified because we have 254 counties. And as was mentioned earlier, we have something called the Indigent Care and Treatment Act, which has different schemes of payment, different schemes of support, depending on where you happen to be uninsured and where you happen to live. It's a very complex system. Some counties who spend more than 8% of their tax levy on indigent care get state support. The large urbans, which cover most of the uninsured in the state, Harris County, Dallas, Tarrant, Bexar, El Paso, Lubbock, et cetera, they spend a considerable portion of their tax dollars on there. In Bexar County, it's somewhere around 45% of our county tax dollars go to indigent care. Hence the incentive to do something very efficient when you're at 45%. And we don't get state support. So it's a different scheme in the Indigent Care and Treatment Act. And you can see from the map that the orange part is, according to this, and this is from CPPP, Center for Public Policy Priorities, and they've identified, this is a little bit dated, it's 2005, but there's a map that I saw yesterday on the New York Times. Had I seen it earlier, I would have included that instead of this one. But the New York Times has an interactive map by census tract for the whole country. And so you can zero in on where you live, and where your community is, whether in Texas or elsewhere, and look at it by census tract. So what do we do in Bexar County? Bexar County established a CareLink program. Now, the hospital district was set up in 1955. So before 1955, we had an episodic approach to it. We just provided care as we needed to provide care as people walked in the door. We did in 1997, as we had a lot of discussion internally, is that how do we promote health? Remember, that was a time we were talking about, it's not just about sick care, it's also about trying to improve health care for the community. And how do we encourage folks to do the right thing? And how do we give those folks who do the right thing priority access? So there was a lot of discussion. And so the end result is that we came to Travis County, and we talked to a woman by the name of Debbie Blunt. Debbie Blunt was in charge of the Travis County Indigent Care Program, and later on became Medicaid director. And we asked Debbie to come to San Antonio, and she helped us set up the CareLink program. It gave us a lot of information about what Travis County was doing. And then we put it on steroids, because one of the things that Debbie didn't have was a provider network. She was the payer, but she wasn't a provider. Today we have about 50,000 or so members. We used to have as high as 60,000 in 2009, 2010, when the economy turned south and people lost their jobs. People came to us, but as the economy's picked up, the membership has dropped. So when I saw this about 6 months ago, it was at 51,000. Now it's at 49,000. That's a good trend. So, and the one thing I wanted to say is that CareLink is not insurance. It is a program that the hospital district operates that assists people with care. The biggest difference with insurance is that it doesn't cover pre-existing condition, and everyone in CareLink for all practical purposes has a pre-existing condition, whether it's a health condition or a trauma or something. So how does it look? It mirrors the demographics of the community. San Antonio is about 60% Hispanic, and so is CareLink. But we have a good spread of the folks who need CareLink. And then how do we set it up? Most programs that provide assistance have a cutoff, and it's a pretty hard cutoff. If you make $1 more than the formula says, then you don't qualify, and you're out of luck. So if you take Medicaid or the indigent care programs that counties run, it's really around 21 or 22% of federal poverty. So if you make, and to translate that into people terms, that means if you make more than $4,500 a year for a family of four, not a month, a year, you don't qualify. So it's a hard cutoff, and we wanted to avoid that hard cutoff. So we developed several tiers, because we know that the working poor sometimes have jobs, and sometimes they lose those jobs. Maybe there's a construction job or some sort of a temporary job, and so we created these tiers to create some flexibility. Because if someone is ill, and like the prior speaker mentioned a few minutes ago, you want to provide them care. You don't want to leave them out on the street. The problem's not going to get better with time if you don't address it. And so you want to address it at the earliest possible time. Take care of it when you can control the cost, when you can provide primary care as an intervention and save dollars, rather than wait for them to have pneumonia and end up in the hospital and have a 3 or 4 day admission. So we developed these tiers, and the tiers have corresponding responsibility components. The more you make, the more your responsibility is. And this is the way the membership breaks down. Most of the folks in CareLink are below 150% of federal poverty, but we do have quite a few that have good jobs, maybe lose their insurance, and then are sick and have cancer or something and need care, and they enroll in CareLink. So CareLink goes up to 300% of federal poverty. Again, we tier it with additional responsibility. The purpose of this slide was to kind of communicate to the audience that CareLink is not a standalone program. We're not an organization that just runs a CareLink program. We're an organization that provides care. We run a hospital, we run their ambulance program, we have an HMO, we have a physician group with 126 providers. We have an affiliation agreement with the school, the UT Health Science Center in San Antonio. They have 900 providers. We are, our main job, day in and day out, is providing health care. What CareLink does is it structures how we provide that health care within our provider network. And the more efficient we make our provider network, and so, for example, let's just take nursing care. We are a nurse magnet hospital. Seton in Austin is a nurse magnet hospital. All their hospitals are nurse magnet. We're the only public hospital in Texas that's nurse magnet that I know of, and the only one in San Antonio that's nurse magnet. Requires a little bit additional effort on the part of our nurses. Requires a little bit better processes and procedures. But as we improve the system, it also benefits CareLink. And that's something that's very, very important, because as we take costs out of the system, and I was mentioning earlier that we started in 2012 with a lean initiative. As we've improved our system and made it more lean, we've also benefited CareLink indirectly. So this is the gut of the presentation, or the real meat of it. The CareLink is based on a set of principles. When I was a kid, I was a Boy Scout, and we learned some principles. You know, the Scout is trustworthy, loyal, helpful, friendly, courteous, kind, obedient, cheerful, thrifty, brave, clean, and reverent. I still remember them after these years. I thought it was useful to see CareLink with a set of principles, because then it guides you. Because there's a lot of change in our system. You know, you have different providers, different patients, different administrators. You have a good year, you have a bad year. How do you keep it steady and true? And one of the easiest ways to do that is to base it on principles. And so one of the first principles we have is that we promote patient responsibility. And that means, again, as I mentioned earlier, that the more you make, the more you contribute towards your care. It also means that you're expected to participate in our programs. If we have an educational program for your diabetes, like we mentioned earlier, then you're expected to be there. Because it's not just about the money, it's about getting the care and being a participant in that care. We also believe that principle helps us keep the program viable. The biggest problem indigent care programs have had across the country is the fact that they lose viability. They don't have enough resources to carry out. Well, if you have contribution, then you minimize your cost, but at the same time that you minimize your cost, we also have ways to make the program more viable. I'm going to talk about one of our pharmacy gains in a different slide, but let me just talk about how it looks like since 2000. 2000 is when I became responsible for the CareLink program. We started keeping data. And you can see that the red bars indicate the payment that the CareLink members make on a monthly basis. And we have a different tier system depending on, and if you're above 150%, we automatically draft from your checking account your monthly obligation. We don't even send a bill out, because you've signed a contract, you know, and so if you're above 150% to 300%, we take care of that for you, and that's the way that works. The blue bar, or the blue component of that bar, represents the copay. So there is an expectation that CareLink members pay a copay for pharmacy, and again, it's tiered. Someone in CareLink A, which is the lowest level, has a different copay than a person in CareLink C. And also, we have copays for emergency room and for urgent care. We want to steer people to their primary care doctor. So if you go to your primary care doctor, there's no copay. If you go to an urgent care, there's a small copay. If you go to the emergency room, there's a bigger copay. And so the purpose of a copay is not so much to make the money, although we made almost $5 million from copays in 2012. The purpose of really copays is to change behavior. And so that's the reason we have a copay. Another principle is that, regarding CareLink, is that we can't do it alone. We need community partnerships. And so we have relationships, we have contracts with faith-based organizations. For example, Daughters of Charity Service, which is owned by the Seton system, has a contract with us in San Antonio. But so do the FQHCs, and so does the local MHMR center, and so do some private physicians. There's occasionally physicians, it's like a dermatologist or a rheumatologist that the university doesn't really have a lot of, and so we contract with a private rheumatologist or private dermatologist, and in the past, cardiologist. to provide care for our CareLink patients because it's more efficient. And we don't have to build clinics for that. We just contract with them. And that's one of the big advantages of developing community partnerships is that it's not all about bricks and mortar. It's really about providing service. So I'd mentioned earlier that one of our principles is the medical home, and I think it's probably obvious to this room. Why? Because you want to promote that doctor-patient relationship. You want that continuity of care. What better way to make sure that the patient is getting the right care than a formal relationship with the doctor? That's what we have in this room. We all have private insurance, and that's really the intent of CareLink. Staff tells me that 100% of our CareLink patients are assigned a medical home. About 97% actually use it, so that's a really good result. And when we find those outliers, we try to talk to them and say, why are you not going to your primary care doctor? And we're able to do that because one of the other things, going back to our prior slide, is we have an integrated electronic medical record from our prevention clinics to our primary care clinics to our specialty clinics to the hospital itself. It's all in the same EMR, and so we can actually see the patient across the system and where they're going for care. We don't have, again, the resources to do it by ourselves. In addition to our 13 primary care locations that we have and University Health System, we have 21 other ones in combination with UT or the federally qualified health centers or private physician locations. One of the challenges in an academic medical center, and Dr. Schwartner here probably can relate back to his time that he was a resident, is that there's part of the training is without supervision. Sometimes it's with supervision and of your faculty or your attending physician. And one of the things that we wanted to do to improve that training mission is that we wanted to make sure we had evidence-based metrics in the training of our doctors, of our nurses. So we put in clinical decision support tools in our EMR like McKesson InterQual or Hayes Technology to be able to guide the doctors to the right decision. There's an awful lot of waste in medicine where people are getting the wrong care because they think they need this or the doctor thinks they need that or the nurse suggests this or whatever. And if you stick to evidence-based principles, you can actually reduce the expense and provide better care and save, and it's not only improving the quality but saving the dollars. We have case management initiatives. We have prevention initiatives. A cancer initiative that we have, for example, we've identified 10 patients, and I had a meeting about 2 weeks ago, right before Christmas with our CareLink folks. They've identified 10 patients. They need bone marrow transplants. We don't provide bone marrow transplants at University Health System. We're going to help them register for the exchange. We had a little pushback. One of them went to the paper and said, "Why are you trying to throw us off CareLink?" But after we explained to that person that that Methodist system in San Antonio provides a bone marrow transplant, and if we register that person we facilitate that, they're going to have coverage, and their coverage is actually cheaper than their CareLink payment. That's another thing we try to do is that we try to find other sources. Again, going back to that 45% tax burden that we have a responsibility for the mission of trying to care patients, but we also have a responsibility to the taxpayer to do it as efficiently as possible. And if we can find another source, then we're gonna try to move the patient into that other source and encourage them to take advantage of another payment source. I think that you all would agree that if one of the least expensive ways to treat a patient when they're ill is through medication. If someone has a bacterial infection and you give them an antibiotic and it takes care of that, that's much better than having an office visit, or that's much better than having a specialty visit. It's much better than having them go to the emergency department or to take up a hospital bed when they don't need to. And so we really promote this. And there's a in addition to getting 340B savings, which is what hospital districts are able to qualify, public systems, which is really about 40% less than what the commercial market is for medication. So we promote making sure the patients get the medication. We try to reduce the bureaucracy for getting that. But we also work with the pharmaceutical companies, and I can tell you that last year we received $15 million worth of free medication for our CareLink members from the pharmaceutical companies. Since we started in 2000, and actually in 1999, we've received $172 million worth of free medications at the 340B price. If it were at the commercial price, it'd probably be way over 200 million, because just add 40% to that. And that's because the pharmaceutical companies have recognized that CareLink is a valuable program. They, instead of giving us the drugs on a we submit a form and they give us the drugs, submit another form. They now send us their pharmaceuticals in bulk, and we put them in our pharmacy, and and our doctors prescribe them, and if they qualify, they get it from that list rather than another list. And so it's a big savings to the taxpayer. So what's $15 million in terms of dollars? Well, 1 penny on the tax rate in Bexar County is 10 million. So it's a penny and a half. So that's a lot. So how many pennies do we have right now? About 24 pennies. So that's a significant savings. So over the life of the program, it really contributes back to the taxpayer. So you can figure ways to do it. And when we work with MHMR, MHMR, the Center for Healthcare Services, I served on their board for about 8 years. We were able to qualify those folks that were receiving care from MHMR, and the same thing. I'm going to wrap it up, and because my time has expired, but I just want to say that in addition to that, we also make sure that we pay our providers based on productivity rather than FTE component, because and there's a quality component to that. And we also measure performance to make sure that we're doing the right thing. We keep data, we keep encounter data. And then I'll just leave you with this last slide. Are there principles here that can be applied for a Texas solution for the safety net? Thank you all very much.
Good afternoon. Glad to get to stand up, say hello to everybody. Representative Click and Representative Zedler, glad to have you in the audience today. Thank you very much for your attendance. As Arlene said, I am on the front lines of healthcare and healthcare policy in the state of Texas. I am a practicing physician, orthopedic surgeon, married to an obstetrician gynecologist. My undergraduate degree is pharmacy. My grandparents and great-grandparents were all pharmacists, and I grew up around small-town pharmacy. In addition to being a practicing physician, my background also includes being the general partner or managing partner of our orthopedic group of 6 physicians. I'm also been on the governing board of an ambulatory surgery center and a principal also in a rehab hospital. So I know a little bit about the business side of medicine as well as obviously the practitioner side of medicine. During my time in the House, I served on public health and on appropriations during the 82nd session. The 82nd session obviously was a very difficult session from a budgetary standpoint, and under Dr. Zerwas's leadership, we were able to write a budget, in particular to the Health and Human Services. On the Senate side, I've been on the Health and Human Services Committee and recently been appointed to the Sunset Commission, which will be reviewing all the health care agencies in the state of Texas. I think the title of this discussion was Innovation in Indigent Care. I'd like to focus on one aspect of healthcare, Medicaid, and in particular Medicaid expansion. There are those that might think that Medicaid expansion is an innovation in indigent care, but as envisioned, Medicaid expansion is not innovation. It's just more of the same. I'm going to talk to you about some of the reasons I feel personally that we should not expand Medicaid under its current form in the state of Texas, and also tell you some of the principles and potential solutions and avenues Texas should take. But just briefly to tell you, Medicaid, for those of you who might not know in the audience, Medicaid is a state-run health welfare program. It is a state and federal partnership. It's state-run but dually funded. But we are unequal partners in that partnership. And that's because our federal dollars, our tax dollars that we send up to the federal government are turned around and come back to us as Medicaid dollars, but with golden handcuffs, with regulations, with mandates, with restrictions of how we spend that money. Legislatures also, in addition to this problem, the process problem of how Medicaid money flows, have over time slowly expanded the population groups that Medicaid serves. Initially, when it was first funded and set up, it was the aged and blind. It was expanded to the pregnant women and children. And then obviously to people with intellectual and developmental disabilities. Now, Medicaid under Obamacare, and thank goodness for the Roberts Supreme Court ruling, Medicaid under Obamacare was envisioned to cover able-bodied, independent, productive adults up to 138% of the federal poverty level. This is a fundamental change in the concept of health welfare, from helping those who cannot help themselves to helping those based solely on an income level. So the reasons I do not support Medicaid expansion as envisioned are as follows. I have 5 of them. The first one is simply economics. Medicaid spending is unsustainable. Medicaid is now $58 billion of our biennial budget from 2014-2015, out of a $197 billion budget total. From 1987, the Medicaid spending has doubled to 2000 and doubled again to 2010. It is becoming a larger and larger slice of our budgetary pie. When Representative Zeldler and Representative Click, when we talk about education funding and transportation, criminal justice, and we try to find money for those programs, we are forced to realize that we have an overburdening, overarching problem in healthcare expenditure in our state budget. And that's not just here in Texas, that's in all states. Not only is it unsustainable here at the state level, it's also unsustainable at the federal level. We have deficits approaching $1 trillion a year. We have our debt of $17 trillion and tens, if not hundreds of trillions of unfunded liabilities, primarily related to entitlement programs on the federal level. Those who think that federal healthcare spending can continue at the same rate are simply misguided. And the first cut to these federal programs will be in the FMAP, the percentage the federal government is participating in reference to the Medicaid dollar. And this leads me to something else. This 100% match during the first 3 years is something I actually take offense to. The federal government is acting, to me, like a drug dealer. The first 3 hits are free, and thereafter you start to pay and gradually pay more. Second, Medicaid expansion doesn't fix the access issue. As was said earlier, 25% of Texans are uninsured. 20% of Texas citizens are uninsured. But with the insurance exchanges and the subsidies, the percentage of uninsured only falls to 15%. And if we take one step further, it only falls to 12% if we expand Medicaid. When you add also that 70% of physicians don't accept Medicaid, there is an illusion of coverage that is being portrayed by our federal administration. Thirdly, we should not expand Medicaid because Medicaid doesn't work in this expansion group. Again, the expansion population are able-bodied, independent, productive adults. And in randomized controlled trials that have been published in the New England Journal of Medicine as well as Science, it is shown that health outcomes as measured by diabetes, cholesterol, and hypertension do not improve at the 2-year mark. In addition, we learned last week that ER visits actually go up rather than down when they are placed on Medicaid. And why is that? That's a conclusion that was surprising to some of my legislative colleagues, but none of my medical colleagues. What we are doing is giving a person a no-limit health credit card paid for by someone else for any concern that they might have to shop at the most expensive place, the emergency rooms, anytime they choose. Fourth, we should not expand Medicaid because, quite simply, Medicaid is broken. The current system is bureaucratic, inefficient, and too costly. Why expand a broken system? We need the flexibility to design a program that's sustainable and right for the citizens of Texas. Further, expansion of an entitlement program is very difficult, if not impossible, to alter or stop or abolished later on. And fifth, the final reason we shouldn't expand Medicaid is the moral decay of the individual by entitlement programs, especially in those that are able-bodied and productive citizens themselves. I have a great concern for the cultural change occurring slowly in our society that over time, to me, breeds dependency on the government and indolence in individuals. So, that's the diagnosis. Pretty hard words, but ones I think that are true. What do we do about it? What are some avenues that Texas can explore? To me, first, to have fundamental, true change, we are going to require freedom from federal constraints. That is a block grant to redesign an appropriate and, again, a sustainable long-term health care welfare program for the state of Texas and its citizens. When you look at the trajectory we're on in this country from a federal budgetary standpoint, we are just one crisis away from Congress actually probably acquiescing to this. Congress, in its budgetary process, in the future, I think will need some certainty, dollar certainty, as to what it spends in its entitlement programs. And in the future, I can see a block grant being given because it will be forced upon our Congress. Short of that, Texas can continue to look at smaller waivers, 1115 waivers, to change piecemeal the benefit packages and administration of the Medicaid program for certain covered individuals, including those that are in the 0 to 138% of the federal poverty level. That's what's occurring in Arkansas, to some extent in Iowa. And additionally, and finally, I think we should leverage the system of community clinics, FQHCs, the health-related institutions, the teaching hospitals, to increase access. There are now 9 health-related institutions, medical schools, going to 11 in the state of Texas. There are 70 FQHCs, which have really taken off because of an incubator program placed into existence by the legislature in 2003 and reauthorized in 2009. Why can't Texas, if given the freedom, build a system around these entities? It's possible if we had the chance. I desire to have that chance. All these approaches, though, every single one of them has to include the following principles. I think Mr. Hernandez talked about principles. One is patient responsibility. Responsibility for their own health care, but also responsibility financially. There has to be some relationship between the individual receiving the benefit and the cost of that benefit. And second, we got to get away from fee-for-service pricing and payment. We have to go to outcomes-based payment methodology. We have to have a change in that behavior as well on the provider side. And finally, in the larger context, we have to reevaluate our contract as legislators, as government, with our citizens, as well as citizens' responsibility for themselves and for their families. Thank you very much.
Thank you, panelists. That was all very interesting. It's time for questions and answers. So if you would go to the microphone to ask questions, or you're going to pass it around? Great, let's pass it around. I think the audience is not too large for that. To get us started, I'm going to ask the first question of anyone who cares to answer it. What are the barriers that you've had to overcome, particularly from the state government level, from state law, state policy, that stood in your way of doing more, doing it better? George, do you have an answer? By the way, George was a little bit modest a few minutes ago when he was talking about instituting the LEAN program, when he didn't say that they had been able to save $14 million by instituting that for the taxpayers in Bexar County, which I think is remarkable.
You know, I think one of the biggest barriers we have with the state is that they don't, the people who are at the state level, for the most part, haven't had the experience of being a physician in practice, haven't run a health system, And so one of the things is timing. I mean, we operate at a different speed than they do. So getting decisions made faster, better, faster is better for us. And I think that some of the laws that are in place, the Indigent Care and Treatment Act, really penalizes the large urban counties, but it's probably too detailed of an answer to get into right now. But there's probably some improvement that can be done in that as well.
Great. Terry, as a nonprofit, have you encountered any barriers? And you can speak about things other than state law, just if you have
Okay.
comments about that.
Well, we're not insurance or an entitlement program, so we're not going to be affected as much directly in our patient care with state laws. Medicaid being one as far as their regulations. Barriers, resources for patients are barriers as far as equipment, medical equipment. So we can provide health care, we can provide medications, but the medical equipment can be quite expensive. So we fortunately have quite a few partners that help us out with that. But the other barriers, I think the biggest barriers is the patient barriers when you're serving indigent. Transportation, illiteracy, language. So it's their barriers in delivering quality care that we really have to identify. And when we do identify, we have those barriers, we're able to address them, and we're able to increase the rate of compliance on the patient side. So, okay.
Great. Dr. Schwartner, were able to adequately describe the barrier of the federal government. Are there things that the state can do?
Well, we've been trying to do it for years. I think there have been petitions to the federal government, even during the Bush administration, for a block grant going back to '06. Maybe you authored that, if I remember correctly. And we passed legislation requesting that over the last 2 sessions. We have other barriers too. We have doctors that are so frustrated with the complexity, bureaucracy, and low payment of the Medicaid system that we have 70% of physicians not participating in the Medicaid program. On the flip side, we have problems with overpayment and misuse in the Medicaid system as well. I will point out home health and orthodontia, and in some ways dental health have been problematic recently in reference to payment. So we have an uneven payment structure that also entails physicians in solo practice that get paid X dollars, maybe $17 or $20 for an office visit. When you compare that to other more favored nation payees, such as FQHCs and rural health clinics and critical access hospitals for similar types of services, having dramatically multifold differential in payment scale. So the government's playing winners and losers, and they're not paying based upon outcomes or performance, and that needs to change.
Questions? Yes.
More of a question for the county-based programs. Have you thought about expanding to neighboring counties? Are there restrictions in doing that?
The county-based programs are county-specific. I think there may be legislation to allow that, but our program, which was established, our health system, which was established in 1955, took a vote of the residents of Bexar County, and there is, to have that ad valorem tax. And so it would require similar votes probably from, I'm not saying it's impossible, but that's the way it would have to happen, is that those similar counties would have to have votes of their population. But right now, we're county-based. One of the dilemmas that we have, though, you bring up, is that we get a lot of out-of-county indigent. And, people talk about the undocumented. Well, I tell people when I make this presentation inside Bexar County, anybody outside Bexar County is undocumented. So that's the county line. And any given year, depending on trauma and just luck of the draw, we may get anywhere between $12 to $18 million of expenses that are truly expenses that should be borne by a neighboring county or another county in Texas. And we bear that brunt. And again, going back to that's almost 2 cents on the tax rate. if it's $20 million. So it's a significant problem.
Mr. Zedler, Representative Zedler, at the front, all the way to the front. There you go.
Has anybody ever done a comparison of what it actually cost Medicaid versus the CareLink program? In other words, are there any, hey, if we switch to your program, it would cost us so that X amount so that we can consider using that, statewide?
I would, Bill, I would tell you that whenever you have a charity, a full charity or semi-charity program such as CareLink, there's probably a significantly more watching of the dollars. When you have a unlimited health credit card, Medicaid, and then on the other side you have providers that want to provide services to bill for fees, so they can also profit and be able to sustain their system. Then that's just ripe for abuse and misuse. And there's also the incentive from a legal standpoint to provide a whole lot of care. There's some protections potentially when you're doing it for charity in emergency situations as well. But I don't know the answer to your question, but I would think it'd be significantly more than in a arrangement that had Medicaid, a government payer between the provider and the recipient.
The senator's correct. We've done a comparison in Bear County. It's roughly $100 per member per month. So $200 per payment per month. So it's $2,400 for a CareLink member. So if you multiply that out, it's probably about 60% of Medicaid when you add even the drug benefit, because of our leveraging of the provider network and our leveraging of the free drugs and things like that. So it's significantly cheaper.
Goes back to the incentives. If you have a program set up that incentivizes utilization and has no barriers to entry, you're going to get a lot of utilization and a lot of provision of care. The most care is not always the best care. In fact, oftentimes it's exactly the opposite. And so you really need a system, a wholesale redesign of a system that incentivizes outcomes and incentivizes the individual to take responsibility for their own care. 2/3 of health is actually individual choices, whether it's what you eat and exercise, smoking, wear a seatbelt, sex. Those things can't be changed with a larger pie, more insurance, more care. Those have to be decided upon by the individual, and the only way the individual changes is by assuming some of the responsibility, financial as well as personal responsibility.
And I'd like to throw in something along that line. That's one of the reasons that we at the foundation are very keen on a Medicaid block grant, because the things that induce the personal responsibility are not possible under the current Medicaid program. What you've heard from the CareLink program is a sliding scale. Even the federally qualified health centers are allowed to and do base their services on a sliding scale, and they take care of more primary care patients, uninsured patients, than any other source in Texas, based on a sliding scale. You can't do that, and so you end up with the kind of results that Oregon experienced in the recently released study on what happened in Oregon, which was a very unique case because of certain circumstances that occurred within that state. They had the perfect control group of the Medicaid expansion type population who were enrolled in Medicaid, and another group that they could study that was not enrolled in Medicaid but had exactly the same characteristics. And what that study showed was that there was no measurable outcome in health outcomes between the two groups, but there was significantly more health care consumed, more emergency room usage. And so What we are advocating is that we can provide better care, better health outcomes by employing some of the things that you're hearing from Project Access, from CareLink. Texas needs to be able to decide what's best for Texans. We have another question about halfway down on this side.
I don't know if I need the microphone, but Senator, you talk about pay for performance or outcomes, and in the hospital setting, we're measuring hospital-acquired conditions, morbidity, mortality, et cetera. How do you recommend, or how do you see that happening for providers? I have a hard time with my physicians getting them on board.
Well, in the orthopedic world, there are various scorings for outcomes after a joint replacement, for instance. You can look at infection rates, proper prophylaxis versus some of the things that you do in hospitals and whether or not the physicians are following them. Also, the patients can rate their physicians too. All these things are very controversial and probably not supported by a lot of physicians in that respect, but they are appropriate to consider. In rating physicians by their perceived care by the individual, as well as what is objectively measurable in whatever field you're referring to. And there are various objectively measurable parameters for various fields.
Just to add on, that's great for hospital-based physicians, but what about the clinics? I mean, I can rate my physicians in-house, my internist, my pulmonologist, you know, how many VAPs do you have, how many orthopedic skip protocols do I follow, et cetera. But what about those docs that don't visit my hospital, that are only in the clinics, primary care clinics?
Well, you can measure based upon proper evaluation of certain conditions and proper treatment of certain conditions, CHF, diabetes. You can measure hemoglobin A1Cs. These are fairly routine types of parameters that internal medicine doctors should be doing when they're looking at a patient and treating them appropriately, in conjunction with patient ratings. There's objective measurements for outpatient settings as well.
We have about we have a physician group, about 130 providers, and the physicians get there's about a $30,000 bonus that's spread out into quarters, and that we actually look at how many of your panel has gone to the emergency department. You know, what are those? How are you taking care of your diabetic patients? You know, what are those metrics are? Well, what about the women? What are they getting their breast exams? You know, through they're getting mammography. We have great access to mammography, but the physician's not encouraging that to happen. So we look at all those quality metrics plus their productivity metrics, and that $30,000 is up for grabs. So they may get some, they may not get some.
I personally would love to be compensated based upon outcomes. If you feel like you're a good surgeon and you can prove it by your work and the data that you submit, and the corresponding improvement in payment is 2- or 3-fold differential, that is a strong motivator to improve care, rather than this 2% or 3% that Medicaid throws out or Medicare throws out for various measures. You have to make it worthwhile to do it, similar to any free market.
Free market is something that is almost totally absent from the healthcare world. One more question, right behind you.
David Hoyer from Houston. As a practicing emergency physician, I applaud all three speakers here. Many of these Medicaid patients currently are basically a plague on ERs. They come in with an entitlement mentality, demanding narcotics, antibiotics they don't need, and they go doctor shopping from doctor to doctor. I recently published an article that's available online called "Does Medicaid Need a Copay?" with the help of John Davidson. And the answer is yes. Until there's reform in the Medicaid program, the problems will persist. So You know, we're much better off with local control, indigent care programs like the first two speakers today, who recognize the importance of co-pays and behavior modification in healthcare.
Thank you very much.